Good evening, everybody, and warm welcome to all of you for our last CBD stream for 2023. And this will be on managing diagnostic errors in medicine and is presented by Ms. Tanya Marie Lopez, who is a partner at Diana and Company. She's a very experienced lawyer and has vast knowledge on this topic. Now, we are waiting for others to come online live. So let me just play something from Dr. Shield, uh, about just a minute plus. So we'll just give time for others to come online. Okay.
We're Dr. Shield, and we do insurance differently than most companies. Things like simplifying details so it's easy to understand what makes us Malaysia's most innovative indemnity provider. As a Dr. Shield client, you'll enjoy comprehensive coverage with fewer exclusions. With some insurers, you'll only find out what's not covered when you make a claim. Our policy details are online and easy for everyone to understand. Competitive premiums that don't keep increasing. Many insurers increase their premiums across the board to compensate for losses. Dr. Shield limits the number of doctors insured from high-risk categories, so our premiums start fair and stay fair. Prompt dispute resolutions. We're pro-mediation because settlement and negotiation, instead of endless litigation, is better for everyone. Career and reputation protection. Typically, litigation can drain a doctor financially and emotionally. We limit the damage by both, so our clients emerge good names intact. And peace of mind, because a happy doctor is a good doctor. Our different approach to creating policies means we put you first, before us, so you can enjoy your career and sleep like a baby, even if you've just delivered one. Dr. Shield, insurance with a difference.
Anyway, just a word of thanks to Dr. Shield for helping organize this series of medical legal webinars for you guys. I will start the stream soon, and it's actually a pre-recorded session, but Ms. Tanya will come online live to answer your questions after this. Now, just a bit of housekeeping. This talk will be eligible for CBD point. There's no more scanning with the MMA CBD app, but I'll display an attendance link at the end of the talk so that you will be able to record it manually in the form, and we will upload it by tomorrow. Okay. Um, if you are using Slido, we do encourage you to submit your questions at the end of the talk. And you use Slido, if you're using the web on your laptop, you go to slido.com and enter the code 7606577 to to get to the Slido session. Or if you're watching it from the dobbs.my website itself, we've embedded the Slido Q&A in the web page itself. Okay. So we will display. Sorry, if you're watching this on YouTube and you want to use the YouTube live chat to ask questions, you can go ahead. All right. Just a word to a friendly reminder, if you haven't subscribed to our channel, please do, because we always get feedback from doctors that, oh, we weren't informed of our upcoming live sessions. If you subscribe, YouTube will keep you notified on when our upcoming live sessions are. But as always, we'll post it in our forums for you. And so please stay tuned for any future sessions next year. All right, so without further ado, I'm going to start the streaming the recorded session right now, and will be about 20-minute talk. Okay, all right. Hope you enjoyed.
Hello, everyone. Thank you for tuning into today's webinar. By way of introduction, I am Tanya Lopez, and I am a partner with A. Diana and Company, a boutique practice based in Kuala Lumpur. Our firm was established 24 years ago in the year 1999. And just to share a little bit about myself, I was called to the Bar of England and Wales in 2007, and then to the Malaysian Bar in 2008. I practice mainly in the area of litigation, and over the last 5 years, my practice has been focused in the area of medical legal litigation. The topic of my presentation today is managing diagnostic errors in medicine. I intend to go through some case studies as I feel that that is probably the best way to illustrate how diagnostic errors can occur in practice and what happens when this results in a claim for negligence in court. And I would like to conclude by getting you to consider how you can minimize the risks of these diagnostic errors happening in your own practice. I'll start with a quote from Martin Fisher, who was a German-born American physician and author. And he made this statement: diagnosis is not the end, but the beginning of practice, which essentially means that once the source of the problem is identified, then we can begin restoring our health back to its desired state. So when a condition is given a name, it explains everything or most things about a patient. Diagnostic errors are an inherent risk in the practice of medicine. This happens when healthcare workers make a mistake and a wrong name is given to describe the condition of the patient. This may happen when there is a failure to establish an accurate and timely explanation of the patient's health problems, or a failure to communicate that to the patient. Errors in diagnosis could mean that the patient's diagnosis is missed, inappropriately delayed, or simply wrong. And the effect of the diagnostic error is that the treatment for the patient is missed, and the patient is then put through harmful treatment that is initiated as a result of the missed or the delayed diagnosis. As doctors, you would all be familiar with the usual diagnostic processes. First, we have the classic consultation process. This would include a patient's consultation with his GP, and the process involves history taking and physical examination by the GP if required. Then we also have the test interpretation stage. This is where we have other healthcare providers involved in the process, and this would include sending a patient for an X-ray or for a blood test, where the results are interpreted by other healthcare providers such as pathologists. And this would then lead to some pure diagnosis cases, which I will touch upon later in my next slide. The next step will be the process of following up and tracking of information. For example, if test results are abnormal, are they being followed up? We will later discuss a case where results of a blood test were not followed up and which ultimately led to the demise of a patient. Next is the referral and consultation process, where if an opinion is required by a different specialty, then are we doing enough to refer the patient for a consultation with that particular specialist? Finally, we also cannot neglect the patient consultation process, which is our own study or a doctor's own study of a patient's behavior, including their adherence to any treatment plans that have been given to them. Now, I touched on the issue of pure diagnosis earlier, and I just want to briefly touch on the law relating to these cases. These pure diagnosis cases usually involve other healthcare workers apart from the treating doctors, who are tasked with the interpretation of a patient's condition, either through X-rays or blood reports. I'm sure you have all heard of the Bolam test, and the approach in Bolam meant that while the law imposed the duty of care, the standard of care owed by a doctor to a patient is left to the medical fraternity, i.e. the practice accepted as proper by a responsible body of medical men skilled in that particular art. In other words, medical experts would determine whether or not there was negligence. The easiest way to explain the relevance of the Bolam test in pure diagnosis cases would be by reference to the cases which I've set out below. And these three are the cases on pure diagnosis which I would like to discuss. The case of Penny and East Kent Health Authority. This is a case where 4 cervical smears had been wrongly reported by screeners as showing no abnormalities. However, later, each patient went on to develop adenocarcinoma of the cervix requiring surgery. The question that the court was asked to consider was whether a reasonable screener would have detected those abnormalities. The court applied the Bolam test and relied on expert evidence to determine this and found in favor of the claimants. Next is the case of Muller against King's College Hospital. And this is a case where a pathologist had failed to note abnormalities on a pathology sample, and instead he had misdiagnosed a benign ulcer. Both sides, plaintiff and defendant, called their own witness, and both experts were in agreement that there were features suggestive of it being a benign ulcer. But the question was whether a pathologist exercising reasonable skill and care could miss those features. The court again used the Bolam test and rejected the view of the defendant's expert. The court accepted the view that a pathologist exercising reasonable skill and care would not have missed those features. And finally, the case of Brady against Southend University Hospital. It is a case where the claimant sought damages for delay in diagnosing an actinomyces infection. This infection led to the need for surgical drainage of a psoas abscess. The claim was that the CT scans were negligently, incorrectly interpreted. The court applied the Bolam test and accepted one expert's view over the other. And the claim failed, as the court found that there was a good basis for the radiologist's views in interpreting the CT scan. Now, the effects of diagnostic errors on patient care. Of course, diagnostic errors would affect patient care, and here are some examples of how they would affect patient care. Firstly, increased cost in healthcare. Patients may be subject to more testing, and with more testing, it means patients have to expend more money. Secondly, this would then lead to treatment being more expensive and complex. And thirdly, this would have a direct effect on patients, as it would likely cause them more anxiety. The anxiety may come from not knowing what condition they have, or in anticipating the different types of treatments that they may be subject to determine what condition they do actually have. From the cases that have come to court, we are able to identify some of the root causes of these diagnostic errors. Firstly, we group them as system errors. There may be errors with the system. For example, communication or documentation errors, particularly during handover of care from one doctor to another. Secondly, doctors also work under immense time pressures. And when there are too many patients to see, the history taking of each patient may be compromised. Thirdly, electronic health records. Sometimes with the use of electronic health records, results are not traced in a timely manner, or sometimes they get lost. Then there are also environmental factors. For example, the lack of equipment, space, testing ability, or the ability to seek a referral from a different specialty. And thirdly, there may also be cognitive issues which lead to a missed or a delayed diagnosis. For example, insufficient knowledge or knowledge gaps, or insufficient engagement with patient or patient's family to discover a more detailed history of the patient or obtain more details of the patient's symptoms. And flimsy evidence. This is a situation where the doctor does not dig deep enough to find out in greater detail about the patient's history and merely relies on flimsy evidence to come up with a diagnosis. Now, I would like to discuss the approach taken by our courts in dealing with issues of diagnosis. And the first case is the case of Abdul Ghaffur. In this case, briefly, the complaint was brought by the deceased patient's husband. His complaint was that the medical officer had failed to diagnose that his late wife had suffered from a subarachnoid hemorrhage, SAH in short. The plaintiff alleged that the medical officer had diagnosed the ailment of the deceased correctly, and the plaintiff had alleged that the medical officer had failed to diagnose the ailment of the deceased correctly and speedily from the symptoms and condition of the deceased that she had presented with. And she also failed to send the deceased for further neurosurgical treatment as quickly as possible. The patient eventually passed away. There was evidence that the medical officer had kept the patient under close observation despite not making the diagnosis. The medical officer had also consulted a specialist when she noticed that the patient had deteriorated. The court heard evidence from experts for the plaintiff as well as experts for the defendant. And good news for the doctor, the court found that there was no negligence on the part of the medical officer. The court said that the delay in diagnosis did not cause the death of the deceased. The deceased had suffered from SAH with probable rupture of cerebral aneurysm, where the mortality rate is almost 100%. Thus, any surgical intervention would not have helped in saving her life. In other words, the deceased would have died anyway. The next case is a case which began at the High Court. It was appealed to the Court of Appeal and then subsequently appealed to the Federal Court. And the Federal Court had affirmed and agreed with the decision of the High Court. This is the case of Zul Hasnima. And the complaint here was that the ONG had delayed in attending to the plaintiff and had failed to diagnose labor. And therefore, there was a delay on the part of the obstetrician in performing a cesarean section. And instead of carrying out the emergency procedure, the patient was given drugs to lessen her pain. She had presented to the hospital complaining of abdominal pains. As a result, the patient collapsed. She underwent a subtotal hysterectomy, and her child was born with cerebral palsy. Expert evidence was heard on both sides. The court held that performing a cesarean section upon the patient's collapse was delayed. That means there was a delay in the treatment that was given. However, the plaintiff did not present herself in a state of labor. So it was reasonable for the doctor not to have performed the cesarean section any earlier. Once again, this is a good result for the doctor, and the federal court had affirmed the decision of the High Court in finding the doctor not negligent. This is an excerpt from the federal court's judgment in Zul Hasnima's case, and I'll just read it out quickly. It says, "It is our judgment that whether the first appellant was in labor or not, and whether the cesarean section had been done, and whether the appellant's collapse could have been avoided, are clearly matters relating to diagnosis and treatment. The applicable test would be the Bolam test. It simply means that the medical practitioners had the final say as to whether there was negligence on the part of the first respondent. In this regard, there was a divergence of views among the medical practitioners who gave evidence in this case. Thus, based on the evidence and even by applying the Bolam test, the appellants had failed to prove that the first, or for that matter, the second respondents were negligent in diagnosing and treating the appellants." Now, what is the essence of the federal court's judgment? In other words, the court has said that it is not equipped to resolve genuine differences in opinion in matters of diagnosis and treatment. Therefore, the court is bound to accept the view of a responsible body of skilled men in that particular discipline. In other words, the court will rely on expert evidence, and this would then remove from the court the responsibility of resolving a dispute that it is not equipped to resolve. However, by contrast, different considerations would apply in the duty to advise on risks. In this regard, it is the courts and not medical opinion which will decide whether a patient has been properly advised on the risks of treatment. The duty is said to be noted in the right of a patient's self-determination. The next case is Dr. Stanley Isaac's case. And in this case, the complaint was that the patient was referred from a private hospital to a government hospital with a provisional diagnosis of septic arthritis that was made at the private hospital. When she presented at the government hospital had rejected that diagnosis and instead made a diagnosis of osteoarthritis. The decision proved to be fatal to the patient rather. The government hospital decided to undertake fresh blood investigations. However, the blood sample had clotted and couldn't be used. There was no follow-up. Thus, the need to rule out septic arthritis was forgotten and ignored. The next day, the deceased suffered an episode. Pus was found in her ankle joint, which confirmed the diagnosis of septic arthritis. The defendants proceeded to admit liability, and the trial only proceeded on the assessment of damages. And the last case I want to discuss is Dr. HK's case. And the patient in this case had presented with a giant retinal tear with detachment in his right eye. The patient subsequently underwent 2 operations. First, on the 26th of August of 1999, he underwent a retinal detachment operation. After the first operation, the plaintiff returned to see the doctor, and the doctor noted that the retina of his right eye had folded outward. A couple of weeks later, on the 21st of September 1999, a second surgery was carried out. Subsequently, and unfortunately, the plaintiff suffered total loss of vision in his right eye. The court heard from experts for both the plaintiff and the defendant. And the experts' view was that the second operation would have only been necessary if there was retinal detachment. Since there was no retinal detachment in this case, the court found that the Bolam test was not satisfied, and the court found the doctor negligent in subjecting the plaintiff to an unnecessary second operation. Developments of the Bolam test. I touched on this briefly earlier. The Bolam test is essentially where the medical practitioner has the final say on whether or not there was negligence and not the courts. However, this is a single and all-encompassing test. The Bolam test did not make a distinction between diagnosis, treatment, and advice on risks. However, the federal court later in Fu Fiona approved the test in Rogers and Whittaker's and made a distinction between the standard of care for diagnosis and treatment and the standard of care for advice on risk. In matters of diagnosis and treatment, however, which is the subject of our discussion today, the Bolam test would still apply. This simply means that the medical practitioner has the final say as to whether or not there was negligence. We've now come to the end of our discussion on diagnosis. To sum up, I would like to recall the following points. Number 1, diagnostic errors are an inherent risk in the practice of medicine. Number 2, diagnostic errors affect patient care and increases the cost of healthcare as a whole. Thirdly, we have also seen how the courts have dealt with issues of missed or delayed diagnosis through the case studies that I have discussed. And finally, and perhaps most importantly, the Bolam test will determine the standard of care for diagnosis and treatment, which means that expert evidence is essential as the courts themselves are not equipped to resolve disputes relating to differences in opinion in diagnosis and treatment. Some strategies that I can think of which may potentially reduce diagnostic or minimize diagnostic errors are, firstly, self-assessment. This would involve building your own knowledge bank, going through past cases and notes, and seeking the opinion of fellow doctors and senior members of the profession for advice. Secondly, teamwork makes the dream work. Working together has endless benefits, particularly in healthcare. When in doubt, please consider a referral to a different specialist. And finally, continue to seek knowledge, and this includes listening carefully to the patient's concerns. Think about the patient's symptoms and challenge your own diagnosis if need be. With that, I thank you for tuning into today's webinar. Please reach out to us if you require any legal support. Thank you.
Okay, my bad. I forgot to unmute myself. Thank you for the excellent presentation, Tanya. And that was stream of a recorded session, and I brought Miss Tanya Lopez on stage live, ready to take your questions. Let me see. I think the questions are coming from YouTube live chat. So you can see on the column on the right hand side, there are a series of questions. Okay, I'll highlight one first. How can we effectively balance the need for thorough diagnostics with time pressures often faced in medical settings?
Okay. Firstly, hi. Good evening, everyone, and thank you, Dr. Allen,
Yeah.
for the nice introduction and for having me here this evening. I'll just get right down to answering the question. Thank you for that question. It's actually a very good question, and it's something which I touched upon in one of my slides earlier. This being the issue of not having enough time to take sufficient history or sufficient examination of the patient, um, and then that may then translate to not to a delayed diagnosis or even a misdiagnosis of a patient. And system issues are very prevalent in the healthcare industry, and I think they are recognized, especially in public hospitals where doctors work under very high time pressures, and the demands are a lot greater on them. So I think, how can we effectively balance? I would just say that you just need to do your best um, in balancing your own time that you spend with the patient. Once the patient comes in, ask them what their symptoms are, do as best as an examination as you can. And if you feel that you cannot ascertain or cannot come up with a diagnosis there and then, perhaps then it may be advisable to get them to come in after a week to reassess them after giving them some medicine, just to come back and see what their condition is like. Has it improved? Also record their whatever grievances that they have, whatever complaints, and if it is needed, maybe refer the matter out to a different specialty to seek advice from them. But with time pressures, of course, you can't always spend as much time as you would like with the patient. So I think this is something that the courts understand as well. And as long as you have done your part in making sure that you do not miss any obvious symptoms or obvious uh, presentations in the patient, I think there should be enough room for us to defend a claim for a delayed diagnosis or a misdiagnosis. But of course, it's always advisable to reach out to the patient again, ask them to come in for a follow-up review, or even refer them outside for a second opinion if necessary. I hope that answers the question.
I have something to add on to that. Sometimes it's not just time pressures, but it's also resource constraints. Maybe we are doctors working in a more rural hospital where a particular diagnostic, be it a scan or sophisticated blood test, is just not available. Maybe not even in the country, and nowadays people are very clever. They read up, they Google
Mm.
their thing, and then they say, "Oh, you didn't order this scan or this particular blood test, and therefore the diagnosis was delayed or incomplete or some." I mean, this sort of liability because of resource constraint. I mean, how far can it go? Can the practitioner be found fault? Uh, or should we be pushing all the buttons and then doing our best, sending the patient travel 300 miles away to get a scan just because it's not available in his hometown?
Um, s- so that's a very good point. Actually, resource is an important consideration, and you are right in saying that in the more rural hospitals, you may not be getting the resources that you need. But of course, patient welfare is always paramount, and if there is a need for the patient to undergo a certain scan, and if that facility is not available in the rural hospital, then I would think that it would be prudent for the doctor, the treating doctor, to make a referral to a bigger hospital, a primary care facility outside with the facility to manage the patient and then make the necessary transfers. And I think once that is done, then I think the doctor who is having to answer the question on liability will then be able to say, I've done my best. Given the resources that I have, I've done my best. There's nothing more I can do based on the resources that I have. So I think referrals are very important. And we have seen this in some cases as well, where smaller hospitals are probably not as equipped as the bigger ones. But of course, this is not something that the doctors can handle themselves. And if they feel that the scan is essential, then as long as they've made the necessary referrals, then that should be sufficient for them.
Okay, that I think question three is a bit related because in complex cases, how do you recommend navigating the challenge of interdisciplinary collaboration to minimize diagnostic errors? So I think this is where the generalist may need to refer to a specialist, and again, it may be a logistic issue, especially in smaller hospitals where certain specialties are not there. And sometimes it's not always possible to refer the patient. The patient may not be fit to travel, may be immobile, may be intubated or even ventilated. Um, I mean, we are now, I mean, from my perspective, in the last 20, 30 years, the standards of care have gone up and up and up, and expectations too have gone up and up and up. And sometimes I do not know whether it's realistic or unrealistic. Uh, but here we are stuck. I think there was a recent case where a physician was found liable because he did not refer to the appropriate specialists, and I think there was an adverse outcome. And
Yes,
also, I think there was another case where heart attack was allegedly missed in a hospital because the ECG was not it was done, but how some for some reason it was missed. So I mean we sometimes don't refer because maybe the the diagnosis was not clear in the first place, um, or sometimes because the specialist is not easily reachable, or it's easy enough to say refer, but sometimes we can't even get hold of the appropriate specialist in a hospital 50 miles away, that sort of thing. So what,
yes.
what do you recommend?
Um, Look, I think the courts are also aware that in certain conditions, especially in the more rare conditions, the symptoms that the patient presents with are not very obvious to the doctor. But I think if the doctor can pick out and diagnose the condition of the patient based on a more common condition, that means make a more common diagnosis rather than diagnose a rare condition, and then maybe later on follow up with the patient, and then if the patient still presents with the same symptoms, then there should be some alarm bells ringing for the treating doctor and say, hey, you know what, maybe this is not the right diagnosis, it's time we refer. I think if the doctor has taken that step to make that referral to either a colleague within his specialty for a second opinion or from a different specialty, I can appreciate it's not always easy, but I think if that attempt is made, at least that should show that the doctor did not just rely on his own diagnosis. He was, in what I said before, he was challenging his own diagnosis because of the patient did not seem to improve on his symptoms after the first consultation. So I think if we can show to the court that yes, the doctor himself wasn't satisfied when the patient came back. He challenged his diagnosis. He sought a second opinion. He offered a referral. That should, I think, be enough to absolve the doctor from liability, all things considered equal on other aspects.
Let me give an example. I remember in my younger days, we talk about appendicitis, and the thinking was nobody can claim to get a diagnosis of appendicitis 100% correct all the time in a patient presenting abdominal pain. If you really get the diagnosis 100% of the time, it means you're actually missing some cases. And that was the axiom behind it. I think on clinical diagnosis, we will miss some cases. Even in the
Yes.
most astute clinician, it's impossible to be 100% right just on clinical assessment. And nowadays, we may have CT scan to help aid the diagnosis. Again, that facility may not be available in every center.
Mm-hmm.
Um, and then you send the patient home, and even you say, "Oh, do come back if it's not better," and the patient later presents with perforation and then blames you for delayed diagnosis. I mean, where does all this stand, in the challenge of resource as well as referral to interdiscipline? So you're a GP or a primary care physician, and then you didn't refer to the surgeon in time. But how do you get the diagnosis right 100% of the time? You're only human.
Correct. And I think the courts have recognized that the diagnosis must be done in a sequential manner, like day-to-day presentation, especially if you're talking about patients who are admitted to the hospital. And I think we've seen this in one of our cases where there was a case where the patient had presented with food poisoning symptoms. And in effect, the patient was suffering from a cervical epidural abscess, which was diagnosed only much later. But the court held that in that case, if I'm not mistaken, the court held that it was not unreasonable for the doctor to diagnose those symptoms as gastroenteritis or food poisoning, because the court also recognized that because after each treatment for food poisoning, the patient's symptoms had improved. So there was no reason for the doctor to query further and dig deeper to see whether there was anything more sinister happening to the patient. So again, this is a case by case basis thing, and also depends on the symptoms that the patient presents with, how obvious it is. So I suppose that's just one example where the courts were uh, citing the doctor in the sense that could not find fault with the doctor in making the diagnosis that he did, even though the diagnosis of cervical epidural abscess was in fact delayed.
So I guess what you mean is if the diagnostic difficulty increases, then I think the humanness of the doctor does come to the thought processes of the court, I hope,
I I think so,
because
doctor. I
sometimes,
think that's
mm,
I agree. I agree with that statement. I think that is true. I think the court does see that the doctor has taken the effort. He has taken the necessary steps to diagnose the patient, and he has seen improvement in the patient. There's no need to dig deeper unless the patient has come back many times with the same symptoms. Then perhaps then he should be querying or doing further tests to rule out certain conditions. But I think in that particular case, the court found in favor of the doctor to say that what he did was right. He had the patient's symptoms were clearly that of gastroenteritis. He had treated those symptoms. When the patient came back for review, he no longer had that symptom, so there was no need for the doctor to go and dig deeper to find other symptoms. And of course, when the patient presented much later, it then happened to be this abscess, which unfortunately led to an adverse result on the patient. But still, the court found in favor of the doctor.
okay. Let's move on. I see some questions in Slido, but the talk is on managing diagnostic errors. So, can we restrict questions to this subject, because there are some other medical legal questions in the Slido. So we'll just proceed because there are a lot of questions in the live chat. Um so can you share examples of successful strategies for improving communication amongst healthcare professionals to prevent diagnostic mistakes?
Hmm. Okay, the question is on improving communication amongst healthcare professionals. So what I can think of is what I mentioned in one of my slides, which is on teamwork. And teamwork does not just mean discussions between one specialist and another. It could mean a discussion between the doctor and the pathologist, or the person who reads the X-rays, or the lab technicians who have done the blood tests for the patient. So I think it involves a lot of teamwork and a lot of discussion, especially if you're querying something that does not seem right in the report. but and what you see on the report does not actually correspond with what is written by the either the radiologist or the lab technician, perhaps then query it. Um, and of course, as well, if say for example there are two different specialities who are treating the patient, a physician and say a surgeon who are both looking after the patient. And if the physician notices some symptoms that the surgeon may have missed, perhaps he can then tell the surgeon that, look, have you noticed that this person also has these symptoms? So I can't stress or emphasize enough the need for discussion between the various healthcare providers, and I think that that is the only way that we can at least mitigate the occurrences of diagnostic mistakes.
Yeah, I think quite often, let's say the pathologist may not be aware of certain clinical bits of information. So the clinician, when liaising with the pathologist, it helps. I think talking, same thing with talking to radiologists. And I think by close communication, actually the diagnosis may be refined and maybe errors in diagnosis may be avoided as well. And I think
Precisely.
the question is, yeah, the problem is when doctors are more isolated and access to specialties or the person making the report may be not easy because they are not in the same center, and I
Mm.
think there are some barriers to communication which I hope can be lowered in the future, perhaps with technology, with collaborative platforms and so on. I think it's very, very important, but um, I think what you say about interdisciplinary cooperation and communication is extremely important.
Yes,
Okay.
and this would even include the, if I may just add this, sometimes when you make a referral, you're requesting an X-ray or a CT scan, and then the primary care doctor has to make a written request to rule out something, to rule out a certain condition. So I think providing as much information as clearly as possible in that request to the radiologist or to the lab technician would assist them as well in coming up with their report. Because the primary doctor is the one who is actually examining the patient and noticing their symptoms. So it would help, I think, if they provide as much detail and clarity in their request.
Okay. Um, I'll just backtrack a bit to an earlier question, which pertains to advancements in technology or even artificial intelligence being used in medical practice now. I mean, increasingly, we are seeing how AI may be used to screen your cervical smear. So, the case you presented in the UK where diagnosis was missed, what if the AI, which is maybe approved and validated by the health authority, misses the case? Who is liable? Is the AI liable? Is the health
This
authority
is
liable?
this is a very interesting question, doctor, and honestly, I do not know the answer to that question as well. I have heard of certain apps or websites now which help with diagnosis. Can't remember the name of these apps, but it's an app, Diagnosis DX or something like that. I can't remember. If you key in the symptoms, then they come up with the possible diagnosis for the patient. But beyond that, how the courts would hold or how the courts would find if there's an error, I don't think I'm in a position to comment today because I've not come across any cases on that yet. But I think those
Yeah.
would help a doctor in the practice at least to give you options, or what you can consider um, as a potential diagnosis for the patient.
It's already happening, even I know there are some screening for lung cancer, X-ray screening, which there's now AI being employed in the local
Hmm.
clinics. There are some companies trying to see how it can be used, and with the hope that we can screen for certain conditions like lung cancer and you know better pick up. AI is not
Hmm.
just very good at pattern recognition, but they cannot, unlike a human, they don't get tired, so they can screen repeatedly.
That's
Um,
right.
but yeah, I think that's an area which is actually emerging, and I think we need to be able to define boundaries of responsibility, ethics, and so on. I think there's a lot of
Absolutely.
issues to be discussed here. Okay. Um, let's move on to this question on what is the impact of cognitive biases on diagnostic decision making, and how should we address it? A bit more difficult to wrap your head around. I suppose it means that perhaps certain, if say I'm an ENT specialist, when I see somebody, I only think around the ENT sphere. I may not think
Mm,
out. Is somebody with eye that doesn't open very well. Maybe I don't think of rare neurological conditions. I mean, looking at EN, just uh, as an ophthalmologist, maybe just specific diagnosis related to the eye, but not systemic disorders. Um,
mm,
how uh, how do the court see this? You know, I mean, specialists are not know it all. We are rather very blinkered and know a lot about our condition,
mm,
our specialty. But if we sometimes we get systemic disorders or other disorders presenting with signs or symptoms related to your specialty, but not your specialty focus as far as the disease is concerned.
mm.
I hope you
Um,
understand what I mean. Yeah.
yes, yes, I do. And again, it's a very general question for me to answer as well, because at the end of the day, if going by your example, Dr. Allen, about the ENT, looking at a condition for
Yeah.
the
I mean,
eye,
I thought that. Yeah. Mm,
ophthalmologist,
mm. Yeah.
or
Sorry.
ENT, sorry,
Yeah.
ENT. Um,
ENT or ophthalmologist, if they see something related to the organ,
mm,
and sometimes you may not think about a more general diagnosis, which is out of their
yeah.
specialty. Yeah.
So I suppose the question for the court would be then, should they have looked beyond the condition of the should they have looked beyond the ENT condition or the eye condition? Should this particular ENT surgeon have considered other conditions? And this is where the expert reports would be important, and to see what a reasonable ophthalmologist or ENT surgeon would have considered in examining this patient. What are the potential diagnoses that could have or should have been ruled out? Um, Things like that. So this is where I think the expert evidence is paramount, because it's if you ask me how the courts view such positions, they would obviously fall back on the expert reports anyway. And if the expert comes to court to say to defend the ENT and say, yeah, okay, it's perfectly reasonable for the ENT to come up with this diagnosis, then if that opinion can withstand logical analysis, then there's no reason why the court should find otherwise. So I think it all boils down to expert evidence in situations like that. What is reasonable, what should have been done, or what is the reasonable thing for the treating doctor to have done. I hope that answers the question.
Yes. Thanks. Yes, it does. Let's move on to Slido because we have one question which is related to diagnostic errors from Dr. Kuharaj. At the top there, you see if there's an error of diagnosis by the clinician due to reports prepared by an unlicensed practitioner. What is the extent of the liability faced by the doctor?
Okay, that's an interesting question. So I'm assuming that the diagnosis was made by the second treating doctor, and he
I
had
don't know what
relied
is
on an
meant.
initial.
Initial report. It may be.
Yeah.
Mm,
If it was I still think that it would be prudent for the second doctor not to merely rely on the report, unless of course the report you're talking about the X-ray or a blood test result. But I think in terms of presentation of the patient, it would be prudent for the clinician to make their own assessment, especially if that patient was referred to you. Start afresh, make that own assessment for yourself. And perhaps you may even think of a different diagnosis compared to what is stated by the unlicensed practitioner in his report. So I think if you have taken that step to make your own assessment and rule out certain conditions, then it's all very fact sensitive. I'm sure you understand that medical legal cases are very fact sensitive, and it really depends on what the extent of the report is by the licensed practitioner. Should the clinician have relied on it 100%, or ought he to have done his own examination, things like that. But I think as far as the clinician who is treating the patient is concerned, he owes a duty of care to the patient. So he needs to make sure that he has done everything to fulfill his duty of care to the patient. And if that means reassessing the patient from the start, from scratch, then that is what he must do.
There are a few other questions on Slido, but from what I can see, they're not quite related to
Mm.
diagnostic errors. Shall we move on? There are a few more YouTube live chat questions. Is it all right with you, Tanya? Unless you want to
Yes, yes,
address
no
those
problem.
questions,
I'll leave
shall
it
we
to you,
move
Dr.
on?
Allen. Yeah,
Yeah, I mean, I thought those questions on injured in hospital premise and sued more than once, I think not quite related to diagnostic errors. So we'll move on to some more questions from the YouTube live chat. Mm, specific training programs or interventions that have shown promise in reducing diagnostic errors among healthcare providers. Are you aware of any, Tanya?
I am not actually, doctor. Training programs, I don't think I'm aware of any. I think this would be, you would probably know, obviously know more of this than I would. Um,
I think we learn a lot
but
from case example. So like MPS will always bombard us with their uh, regular newsletters about cases.
yes,
Actually, we learn about how we learn actually about errors from errors and
that's right.
you know and examples of what to avoid. I mean, yeah, I think
Yes,
that is
I think
one.
that's brilliant. Yeah, that case studies are actually the best way to illustrate diagnostic errors, and also it serves as a great learning tool for
Yeah,
doctors to avoid such errors from recurring in the future.
yeah. So I think examples like this, and I think I organizations like MPS also do organize CME sessions and on this area. So there are some sort of training programs and other means to help reduce at least diagnostic errors so that you can learn from each other, I think.
That's right.
Um, in the context of emerging infections or new medical phenomena, how can we adapt diagnostic approaches to minimize errors? Hmm. I am not sure what the answer would be here. Tanya, do you?
How can we adapt diagnostic approaches to minimize errors? I don't think it would be any different to how we would do it. We should have done it all along, or that how we should be doing it, which is listening to the patient, observing the symptoms, research, speaking to your seniors, speaking to other specialities. Um, if this patient presents with a particularly unique symptom, perhaps it should be brought to the attention of a head of department. Perhaps it should be discussed as a team with other other disciplines as well. I think that is the same as what we would be doing all along anyway. And I don't see how that should change. I think that should be just the basis of how we deal with diagnosis. Um,
Yeah, I
yeah,
think same thing. If it's something very new or it's unclear, most likely we'll be consulting others or referring the patient. If
correct.
it's something not even identified before, it's a new medical phenomenon. I don't think it's any diagnostic approach you different from what we would do in our day-to-day practice.
That's
And
right.
probably will tell that there's a joke about telling the patient, I have good news and bad news. They said, what's the bad news? You get to name the disease. Something.
Good one.
Yeah. Anyway, Uh, Last question. I think it's coming up to almost 9 o'clock. We got 5 minutes more, so I think just last question. Ethical considerations taken account when implementing strategies to manage diagnostic errors in medicine. Any ethical issues do you want to bring up, Tanya?
Um, I think we know the standard ones about protecting patients' confidentiality. If indeed you want to sit and discuss the patient's case with a colleague, even if it's just to pick his brain about something, but you're not asking for a formal, uh, you're not getting the patient a formal referral to another specialty. You're just merely sitting down for coffee with a colleague and asking the patient, "Hey, what do you think?" Then perhaps I think confidentiality is, of course, paramount. Protect the patient's confidentiality. Other ethical considerations,
If
nothing
we
comes
use
to
social
mind beyond
media,
that. Oh, of
using
course,
social
yes.
media to discuss cases, is it, of course, you can reduce diagnostic errors the more people you discuss with. But what if you use platforms which aren't very
Yeah, I wouldn't
sanctionless?
recommend that at all. Yeah, I mean, of course, if you're gonna keep it completely anonymous, and if it's just to as a learning thing, of course not on Facebook and Instagram, but there might be other platforms which serve as a forum for doctors to discuss among themselves certain conditions. But again, it boils down to protecting the patient's confidentiality. I think that is most important. Um, and Yeah, I think that's about it. I think, Dr. Ellen.
Yeah. Okay. So thank you very much. I think we have come to the end of the session, and the most interesting part for the doctors who have come. Thank you all for participating. Um yeah, just final appeal. End of the year, so my New Year wish is I hope more of you can subscribe so that we can keep you updated with more uh, webinars like this. Um, and we take the trouble to get CBD approval from the MMA. Now, that QR code you see there is not to be scanned by the MMA app. Okay, so I repeat, do not use the MMA CBD app to scan that QR code. I think people have been reflexively see QR code and they try to scan with the. It's just a QR code which takes you to the link. So you can use a normal QR code scanner for the Apple iPhone. You just use the camera, and then when you put your camera in front of that QR code, it will take you to the link, which is dobbs.my/281223, which is today's date. All right. Now, this link is a shortcut to a Google form, and all you have to do is fill in your name, your MMC number, IC. Most important is the IC because the unique identifier is your IC in the MMC system. You get IC wrong, okay. And the form will to prevent abuse. We will expire the link on the 29th. That means at midnight tonight, this link will no longer work. Okay, we'll update. It's not instant, so unfortunate that we do not have the MMA QR code system where you get a point instantly. It will be available only when we manually update this tomorrow. Okay. So Tanya, you see how difficult it is for doctors. Normally, we have very high expectations to getting the diagnosis right. We have very high expectations to make sure everybody walks out well, including people with stage 4 cancers. And
Yes,
we have to have
and we thank you.
uh, 20 CPD points to renew our APC. So there's a lot of stress for medical
Oh,
doctors
yes, there
these
is.
days. Yeah, but thank you for being here, and at least we have lawyers like you to to educate us and turn to if there is ever the need, God forbid. And
It's my pleasure, Dr.
yeah,
Allen, and thanks so much for having
yeah,
having me as well.
yeah, it's a great session. I learned a lot, and I hope you guys who are watching also learn. And I think we learn from each other, and as we move on to 2024. I just wish everybody well, and I hope your medical practice is without any hitch or medical legal drama. And wish you all good night and good health. Okay, Tanya, I'm going to end
Thank you.
the stream right
Sure.
now. Okay.
Thank you.